There we go. Okay, welcome everybody. Looks like we have a pretty small group. It's kind of an awkward hour, 6:30 p.m. Eastern time, but I think we have folks from way elsewhere. So welcome to another VMR. I am discussing with Sharmin today. Sharmin, who's
Woohoo!
helping us?
Uh, Thank you so much, Andrew. I'm so excited to discuss this case with you, and thank you for being flexible. I'm on service, so it's a little easier to do it in the evenings and afternoons. So thanks everybody who is joining us, and a big shout out to Jerome and Himon for doing describing and teaching points. We're really grateful for you all, and Shreyas is doing a case for us today. If we can get the board up, I think we can get started.
Welcome back, Shreyas.
Yeah, nice to be here.
Andrew, I think you need to make me a co-host so I can share my screen.
Oh, okay. We're on it, on it, on it. There you go. Thank you, Jerome.
Okay, can I start?
All right, let's do it.
So this is a 58-year-old gentleman with diabetes and hypertension. He presented to the hospital with 3 days of hemoptysis, which he said was specks of blood on a tissue paper.
That seems like a pretty reasonable place to stop, yeah? Or do you want to give us a
Sure.
little more information?
Sure. Uh, 1 day prior to admission, he said that he had two episodes of hemoptysis. He initially presented the ED when he had this episode, but then he subsequently left because it was getting better, and then he went back home. And due to worsening of his hemoptysis, he came back. At its worst, he says it was almost a tablespoon worth of blood. He denied any recent fevers, chills, or weight loss. He also denied chest pain, palpitations, or other overt bleeding symptoms like epistaxis, melena, hematuria, or hematochezia. Uh, he never noticed any oral ulcers, skin rashes, or lesions. Uh, he didn't have any neurologic symptoms like numbness, tingling, or pain. He just had occasional joint pains every now and then because of gouty arthritis of his left great toe. Yeah, those was the relevant things on review systems for him.
Okay, yeah, that's a really good place to stop. So, when I hear someone coming in with hemoptysis, I first want to take a pause and translate that into kind of blood is coming out per orum. Like, where is it coming from? Because I think we all see blood come out of the mouth, and someone reports cough, and we assume it's coming from the alveolus, right? But it could be coming from really anywhere in kind of the oropharyngeal, mucosal space. And it's really helpful that Shreyas told us that this patient doesn't think this came from epistaxis or nose bleeding, because that's one of those kind of false localizing spaces where people cough up blood, but it's not actually coming from the alveolar space or the respiratory tract. It's just coming from the nose and the mucosa. And the same thing goes for, someone has like a tumor, like a squamous cell carcinoma inside of the mouth. Those sorts of patients will be also coughing up a lot of blood as well. So, in a patient like this, if they haven't noticed anything like odynophagia coming from like a tumor in the oral mucosa, and then we've already kind of considered these like nasal causes that are kind of mislocalized, then I think we get kind of worried pretty quickly because we think that this is somewhere along the respiratory tract, and most morbidly, that would be all the way down at the alveolus. Why that is problematic is if that is quite massive, you're no longer going to be able to oxygenate. You have fluid filling, a region of your lung, and that's like shunt physiology, right? If you plug up an entire area of the lung with fluid, the blood is just going to bypass all of that and be unable to oxygenate. So there's that aspect of things. And the other thing you're thinking about when you're like triaging hemoptysis cases is kind of like the hemorrhagic side of things, like the blood loss side of things. So not only can it cause respiratory compromise, but also hemodynamic compromise. It's pretty rare because it has to be very massive. And if you all haven't heard this framework before for triaging hemoptysis, towels versus tissues. I think it's really great to introduce to you all. So the idea is if a patient tells you they're coughing up blood and they can just use a tissue paper to kind of get rid of it, then it makes you a little bit more reassured that they're not going to have like a hemodynamic collapse right in front of you. But if they're expectorating a lot of blood where you require like a towel to really soak up all of that blood. That makes you a little bit more worried. Maybe you need to monitor this person in the ICU with continuous oximetry and really figure out where this bleed is coming from, because that may cause like hemodynamic collapse as well. So, Charmaine, I guess my initial impressions are probably somewhere like below the larynx this is coming from, given the absence of oral symptoms and the absence of epistaxis. One other thing I wanted to factor in is the absence of pain is kind of interesting, because some of these syndromes at the kind of alveolar pleuritic interface where the blood vessels are, that where that is where the pathology is happening for hemoptysis. It can cause pleuritis and kind of like a pleuritic pain syndrome that can be in the chest anteriorly, like chest pain, or it could be in the back if you're having something like posterior pulmonary infarction. I think the absence of that is interesting. I wonder if that prioritizes something just like an aberrant vessel, something is wrong with the blood vessel inside of kind of like main stem bronchus, or kind of like lower grade, smaller bronchi, where it's not really touching that interface, but so there's something that's still kind of like bleeding there. So I'll stop there. Charmaine, initial impressions?
Absolutely, absolutely brilliant. That's exactly how I think about it. Like my first thought is like, oh, am I dealing with a mimicker of hemoptysis, which you brilliantly discussed. And the second question is like massive, not massive. Do I need to do something first before I think about it or not? But sounds like, the patient is like talking, from what we gather, is like hemodynamically stable. And I really love the tissue versus towel analogy. That's really, really great. And sometimes, like, when the patients come in, if sometimes which lung is a troublemaker, right? They have cancer in that lung, like on the right side. So if you're worried about massive, just like put the lung down. So it's also another good approach to remember is like when it comes to hemoptysis, if it's like massive or you're starting to get into issues with oxygenation and ventilation, you always want to put the bad lung down. So and in terms of like kind of like a schema for like hemoptysis, yeah, I feel like parenchymal issues oftentimes can cause it. As Andrew mentioned, like we don't really see any like kind of pleuritis symptoms, but anything from like bronchitis or bronchiectasis, and any like endobronchial lesions that can do it. And then the vessels is also, I think, like where oftentimes we worry the most when we see that. The one thing that I would say, like, if this patient is on anticoagulation, like similar to anywhere, you can also bleed if you have like a little bit of a pneumonia or something like that. It gets irritated. Having systemic anticoagulation on board can make you even more prone to bleeding, even in from an irritation. So that's also something to consider. But in general, like I often like think about like what could happen with the venous side. Like I imagine my alveoli with like the blood vessels going, like the artery, capillary, and the vein. Like anything, heart failure, oftentimes we think about it can cause increased pressure, that can cause like some hemoptysis. Oftentimes it's like more like frothy blood tinge and not truly hemoptysis. And then capillary, like as a medicine nerd, DH differential is also like one of the favorites to run. And like any AVMs can do it. And then from the artery sides, that is like the one that you worry the most about, because they tend to be like massive breather. If you have like any abnormal fistula, like for example aortobronchial fistula, that they tend to be massively bleed. So those are like the urgent causes of hemoptysis. Often involves some visualization, some connection to the artery system, which is like higher pressures. Yeah, so I agree. Like I would be curious to like hear more about like who this patient is, and also like what the workup shows. Mike, back to you.
Sure. So past medical history, he has type 2 diabetes, hypertension. He doesn't really take medications for hypertension. And his other medical conditions also include gout. Among his prescription medications include metformin, amlodipine, and he uses over-the-counter naproxen for gout flares every now and then. He hasn't been using it just before he came to the hospital. With regards to his social history, he immigrated from Philippines in 2009. He worked as a caregiver to old people in the past, and recently he shifted his job. He's now working as a food delivery agent and a photographer. Uh, travel. He went to Las Vegas 3 weeks prior to his hospitalization, and he told me that he turned on the air conditioner and there was a blast of dust which went into his face. That was the only notable exposure which he had. Family history, no known his hereditary bleeding or cardiovascular or pulmonary disorders. And for his health-related behaviors, he smoked cigarettes for 20 to 30 years. He did quit for 14 years in between, but then he restarted smoking intermittently. Occasional alcohol use. He denies using any vaping products. And with regards to his allergies, no known drug allergies.
All right, is this a good place to stop?
Yeah, I can do aliquot 4 and 5 together.
Okay, wonderful. So yeah, I think like I don't know if this helps me make in much diagnostic progress other than like, he's not on any systemic anticoagulation. I don't see any culprit medications, NSAIDs use cause a whole slew of issue, but nothing that I can quickly tie into like hemoptysis. And I think in terms of like, original, like the whole slew of like infectious disease, a more indolent one can also present with hemoptysis. However, I always like to make note of like where people are from, but and then come back to it later if it becomes more clinically relevant rather than use a lot of like cognitive load right up front. But in terms of like the tobacco history is probably the one that is like the most concerning, thinking about like, oh, if we're dealing with an underlying malignancy that is presenting for the first time at hemoptysis. It doesn't we didn't hear like much weight loss or any other symptoms that would kind of clue us into something more chronic to subacute going. However, people don't read textbooks. So the fact that I'm thinking about like smoking, like vasculitides that can be seen, or like malignancy would be the two things that captured my attention. Any thoughts, Andrew?
Yeah, totally in agreements. Some stuff brought up in the chat, like this idea of TB, lack of weight loss and systemic symptoms would be a little odd. And of course, if we see imaging that's positive for like a upper lobe cavitary lesion, we would recalculate that hypothesis. But other just things that kind of came to mind in hearing the social history is non-tuberculous mycobacterial infection, which is often chronic and leads to a bronchiectasis type picture. And bronchiectasis is the most common cause of hemoptysis in terms of epidemiology. Those people don't necessarily have to waste away in this kind of like Lady Windermere syndrome, where you think of very, very frail elderly people who've lived with this NTM in their lungs, kind of slowly causing them to waste away. But we're not really hearing that story in the HPI of chronic cough, chronic sputum production. Like that's the story of bronchiectasis. So we're not seeing it here. It's really quite acute. We could go back and be missing something in the history here. Maybe we'll get that later. But if this is truly like a one-day disease, I'm getting the sense that something is kind of bleeding structurally speaking, like people brought up tumor in the chat. Like, is this just the first presentation of a tumor or some sort of vascular anomaly that Sharmin already laid out for us? So yeah, I think we need some detailed cross-sectional imaging of the chest to see where exactly this is coming from. And it'll be interesting if the CT chest actually shows nothing. We can kind of take it from there. But I suspect we're probably going to see something in the lungs based off of base rate. So yeah, what do we have next, Reyes?
Sure. So his vitals temperature was 37 degrees Celsius, heart rate 92 per minute, respiratory rate was 20 per minute, and his blood pressure initially on admission was 206 over 131. And it stayed there for some time. He was given nifedipine 30 milligrams, and it went down to 180 over 110 before it finally stabilized at that level. He was saturating 95% on room air, and regards to his physical exam, he was very pleasant appearing, alert and oriented ×3, lying down comfortably. Cardiovascular exam was normal S1, S2, no murmurs, aortic venous distension. On pulmonary exam, there were some crackles to auscultation in bilateral lung bases. Abdomen was soft and non-tender. Neuro exam was within normal limits. Motor and sensory were intact. Skin exam, no rashes, nodules, mucosal lesions or ulcers. And I can give you the initial labs which we had for him. WBC count was 4.9 with a normal differential, neutrophil of 50.1%, lymphocyte of 36.7, and eosinophils of 2.6%. His hemoglobin in the ED was 15.7, and it subsequently went down to 14 just prior to his admission to the floors. His baseline hemoglobin about 2 weeks prior was actually 16.5, and platelet count was 281 and MCV of 94.1. Chemistry was within normal limits for the most part. Sodium 139, potassium of 4.2, chloride 101, bicarb of 24, BUN of 12, creatinine of 1.2, glucose 98, calcium was 9.1, and phosphorus of 3.6, magnesium was 1.9. And we got some other labs as well. ESR and CRP were normal at 3 and 10 respectively. LDH was 150, AST of 24, ALT was 28, ALP was 75, and bilirubin was 0.8. Troponin was initially mildly elevated to 0.046. It uptrended to 0.061, and then it went down to 0.058, and it was stable at that at 0.058. We also got urine toxicology, which was negative. HIV, Hep B, Hep C was also negative. And I have imaging in the next aliquot, and I would like to show some images as well.
And can I ask two questions, Shreyas?
Sure.
The CRP was normal. Is that what you said?
Yes, CRP was normal. Yes, our CRP both were normal.
Okay. And the LDH, is that within normal limits for your
Yes,
lab?
within normal limits, 150
Okay.
was, yeah.
Okay. Got it. Got it. And then you were going to hold off on the imaging because that's completely fine. I think we could.
I can show you the imaging.
Okay.
I can show the
Okay.
imaging, and then we can, I'll just share my screen, and then I can show you the CT, which was obtained.
Okay.
One second. I can show you the chest X-ray and the CT, if that's okay. So this
Yeah.
was his initial chest X-ray, if everyone can see it. That was the chest X-ray. And now I can share the CT if everyone has a good look at this chest X-ray. Now I'm sharing a CT scan. I'm not able to share. I think issue with it. Oh, okay. I think you might need to make me co-host again for me to share.
Ooh, let me see.
Oh, I got it. I got it.
You got it? Okay.
Yeah. Yeah, sorry about that. Okay, so this is the CT scan. There we go. Can go back one more time. Yeah, that was a CT scan.
Oh, I love the images, Shreyas.
Sure.
Thanks for bringing it.
Yeah, sure.
Yeah, so my impression, I love the feedback from Sharmin and the chat too. I don't think we saw any pleural effusions. I think we saw some kind of very subtle patchy ground glass, and I didn't see any large consolidations. Consolidation is when the density of what you're seeing in the lung parenchyma is the same as the blood vessels that are entering, your alveolar units. So if you can't make out that border anymore, that's a consolidation, and that indicates complete alveolar filling. Whereas ground glass is just partial alveolar filling, just like a less severe version of that. But I guess, yeah, Sharmi, why don't I just pass it off to you for your impressions of the imaging, and then I can go back and make some like pre-radiology comments.
Yeah, it was my internet was a little choppy, so I don't think I got the perfect slices. But what I noticed was like ground glass. I think it was like mostly on the right lung base that was most prominent. But sorry, my internet was a little choppy, so I didn't get a good view.
Shreyas, could you give us the official read and then we can kind of give more discussion?
Sure. So the official read of the CT was there was no PE, diffuse bilateral ground glass opacities, right greater than left, and clustered nodularity in the left upper lobe, concern for multifocal pneumonia. And the chest X-ray was read as mild cardiomegaly with right lung base atelectasis and a hazy right lower lung opacity. I can share the EKG, which we got as well. EKG just showed borderline right axis deviation, no ST elevation or depression. There were T-wave inversions in V5 and V6, and there was normal R-wave progression. We also got an echocardiogram, which was normal EF of 55 to 60%. Left atrium was just mildly dilated. Right ventricle was normal. Aortic valve, no stenosis or regurgitation. Mitral valve, no stenosis or regurgitation. And after that, we got some more diagnostic tests.
Okay. Yeah, I think just like taking a step back, even like pre-radiology, the vitals are really interesting. You know, people when they see, I feel like saturation less than 90%, they jump to hypoxemia and really focus on that. Notice how borderline the patient saturation was. It was 95%. The cutoff I use to be concerned is 94%. And that's because if you're breathing fast, you have tachypnea, you're very likely to have a respiratory alkalosis. And if that makes you net alkalemic, that shifts your oxygen dissociation curve to a place where you need a saturation of 94% in order to be delivering a PaO2, you know, your arterial oxygen of 60 millimeters of water. That's or mercury. That's what you need for your organs to basically not be hypoxic. That's 60, the magic number. To get that, again, guarantee at 94%. And that's if you're breathing fast. So this patient is like, you know, if you put them on continuous pulse oximetry, they're 95%, right? They're like technically above that, but you know, they're probably dipping down below that. That was like your key off that something was probably going to be wrong at the level of the alveolus. And then the blood pressure is kind of interesting. You know, if you see very, very high blood pressures like that and the patient looks very sick, you could think of this flash pulmonary edema presentation you see classically in patients with HFpEF, but you can also see in patients with HFrEF in terms of reduced EF. And that's an interesting hypothesis to bring up because if you have so much back pressure, especially in patients on anticoagulation, the high venous pressure can cause just kind of like diffuse hemorrhage and this hemoptysis type picture. But that's like not this patient's story. Like they're coming in just like coughing blood. They're not like in respiratory extremis and super short of breath because they have all this pulmonary edema. Like that's not quite the story. So then the other like reflex thought I had with high blood pressure and what seems to be on exam, confirmed on the imaging, you know, diffuse alveolar process with these crackles and the filling on CT is diffuse alveolar hemorrhage and capillaritis mediated etiologies, which often have glomerulonephritis as a result of that. And certainly this patient could have normal renal function on this initial BMP here, but be still having active glomerular damage from that microscopic capillaritis inside the kidney too. So I think getting a UA here, in addition to that urine drug screen we already saw, is going to be really helpful to make sure that we're not seeing dysmorphic RBCs spilling out into the urine. And I think tying in the echo, that just kind of confirms this hypothesis that what we're not seeing here is kind of this flash pulmonary edema with that high BP. Normal echo does not rule out HFpEF. Just want to put a big disclaimer on that. But in terms of a flash pulmonary edema story, usually the echo looks pretty bad, like gross diastolic dysfunction, a lot of LVH, a lot of LA dilatation. Here we're only seeing a little bit of mild LA dilatation. So this is probably like a chronic HFpEF kind of person, but like this, I don't think that this story is really that of flash pulmonary edema. But yeah, Sharmin, those are just some shotgun initial thoughts. What else stuck out to you?
Oh, no, dude. So good. I 100% agree with you. I saw that blood pressure and I'm like, oh, what is the crap name going to be? And I 1.2, like 1.2, pretty normal. Although, like, it would be nice to know, like, if this person is always like 0.6, 0.7, that could be an AKI. So I 100% agree on a UA, just to make sure we're not dealing with like a initial present, whatever, as you mentioned, like this seems like an acute presentation. So this might be just the start of a process that we are capturing. So getting the UA and make sure we're not dealing with like a glomerulonephritis would be a really important. I feel like, thinking about the ground glass opacities, like GGOs, there are a few things, right? They're either water, they're either cells, they're either blood, they're either like foreign material or pus, right? Common things often, it's water, less likely in this patient with that echo, as you beautifully mentioned. Pus, yeah, maybe. It would be odd, like he doesn't have any other signs of like a fever or any infectious symptoms. However, I don't know. I've been so humbled recently that I don't even know sometimes. But again, like less likely for this to be like pus. And then we're made with blood and with the hemoptysis. Then I really like invoking the DAH. And not oftentimes when we think DAH, we immediately go to capillaritis. And I really like the fact that to also think about like other etiology of DAH that is not necessarily capillaritis and vasculitides. So infections like lepto, for example, that can do it, like vasculopathies that can do it. Cancers we already talked about, and as you mentioned, like increased venous pressure, but again, like with that echo is probably a little less likely. And then I think like if you get signals with the kidneys for like a more vasculitis, thinking about both the post-immune or immune complex mediated processes, would be good. GBM is another one that I often like think about in this category. But I think like it would be cool to think about, Andrew, if you were like we were taking care of this patient. It's like, what would be your next step? What would you do if you're at a hospital is taking care of this patient?
Yeah, it's a really good question because Jazz actually brought up in the chat the stone cold normal CRP is a bit odd for like a glomerulonephritis story. I don't know how much we should rely on that, but I'd probably be looking up how much sensitivity that has for active GN because if it has really high, well, I suppose, I mean, no, we're saying this guy very likely has DAH because we don't have a story pointing us toward any of those other like fluid filling processes and he's literally coughing up blood. So I think if we're telling ourselves it's DAH, our pretest probability is pretty high. So I think we're probably have to send even with that negative CRP the usual GN workup. So your ANCAs, and if that's positive, can reflex your MPO and PR3, the anti-GBM antibody that you mentioned, C3, C4 testing to look for immune complex mediated disease and kind of waiting those out. And I think you can send more complement immune complex workup if that ends up being positive or up front. I think a lot of people do that too, like ANA and kidney biopsy is kind of in there if that's involved too, just to see what's going on, if nothing serologically kind of pops up. But other than those serologic tests, I know you brought up the infectious stuff. It seems like with the negative infectious workup, that's less likely. Just trying to think of like non-inflammatory causes of DAH, like if we do want to put our money on the
Mhm.
CRP here, and like what would that mean? And we don't have coags. Like, what does this guy have crazy high coags? So I think we should probably send that for like coagulopathy, and then you can kind of go down that pathway if that's negative. In terms of
Mhm.
just like non-inflammatory diffuse vasculopathy, like you can have diffuse alveolar damage. I imagine that would be somewhat inflammatory though. If you had a massive insult to your lung parenchyma, that probably will launch your CRP pretty high. But maybe it doesn't. Is this acute dust inhalation event that the patient had? Did that cause diffuse alveolar damage? Probably not. But yeah, I'm honestly curious where this is going to land. I mean, I'm not really
Yeah.
sure. There's like nothing pathognomonic here. I feel like so. I feel like we do have to cast a pretty wide net.
Yeah. Yeah, I agree. And I love the workup that you mentioned, kind of like thinking about the serological workup. But was also like thinking about irritants. He's like started smoking, had this inhalation event that could definitely cause damage. And unfortunately, I feel like that is like your diagnosis of exclusion unless like Palm feels very confident about it. I don't. And the other thing that I would consider in this point is just like bringing on pulm and thinking about bronch. Like if you're really worried about DAH, let's just confirm the diagnosis of DAH, like a better BAL sample to potentially think about some more indolent infections. And I hear you about ESR and CRP. And again, I the fact that it's negative, I don't know if it makes me think like, oh, absolutely not. We're not dealing with the inflammatory process. And I think that's something that could be trended, but also they're not perfect tests. So I don't know if in my reasoning, I'm like putting too much stock on the CRP and ESR at the moment. And I think I would still do a broad net, as you mentioned. All right, Shreyas, you have us on the edge of our seat.
Fantastic. So I forgot to mention, I'm sorry about that. His coags were normal. It was checked when he was admitted. Urine analysis was also normal, didn't show any RBC casts or any RBCs. So we got some more diagnostic tests. We were going along the same thought process. And he had this remote history of what he called a primary complex. And he was also from an endemic place. So we got AFB, sputum, which was negative. Mycobacterial cultures was negative. And we got Legionella, strep pneumo antigen was negative, blasto, histoplasma, both of them were negative, and strongyloids was negative. ENA, ANCA, anti-GBM, cryoglobulins, all of them were negative. So during this time, his hemoptysis was actually getting better. He started noticing fewer and fewer drops of blood day by day, but we still felt just like you had mentioned, to get Pulm on board and see evaluate the hemoptysis. So we consulted them, and they recommended bronchoscopy. And I have one image to show, and then I can pause after that.
Oh, I love the images. Thanks for bringing them.
Yeah, sure. So, okay. So this was his initial, and then this was at the end of bronchoscopy.
What do we think, chat?
That's just such great images.
So I can, so the BAL showed 146,000 RBCs, 1,111 WBCs, and there was serial return of blood on subsequent aliquots of the bronchial lavage.
Yeah,
Any
so I think
thoughts?
I think we're in the same place. No, Sharmi, we just confirmed our suspicion. We went through the ground glass, consolidation DDX, water, pus, blood, eosinophils, parasites, Curton adds that in after Straji's case. Yeah, I think we just confirmed our thoughts here, but we still don't know why. So I think we're still stuck. Well, we have our coags now, but I'm not sure what else we should. Well, we have the ANA, the ANCA now, cryo. So okay, the immune complex workup is like the specific targeted testing is negative. We still don't have our GBM though, if I'm correct. So yeah, sure. I mean, I don't know where we're gonna land on this.
Yeah, yeah, thank you for showing us the images. Those images are good to remember for what a DAH is supposed to look like. And I think, yeah, a lot of our vasculitis workup are coming back negative. I think anti-GBM absolutely is a good one to think about. And I think there are some like ANCA negative, there's some, ANCA is not always positive and it's not a perfect test either. So I think that is something to also consider. Something's going to be pulm limited. Again, we should keep a close eye on the kidneys as well. The other, as you mentioned, like the other things to think about in this category, it's like your APLS type syndromes that, as you mentioned, like systemically can cause issues and present as a hemoptysis, which again, with the absence of any other coagulopathies, any other clots, bleeding anywhere, makes it a little less likely. I do think given we don't have any other signature, like the irritants hypothesis comes up a little bit more if he had like a valley or any other type of a syndrome, that makes it a little bit more likely. I think our infectious bucket is probably very well worked out and probably less likely. So I think like seronegative inflammatories, again, absence of inflammatory markers is rare. And then the other one would be kind of um, our diagnosis of exclusion, as we exclude is the irritant possibility that comes up a little bit higher. Any other thoughts, Andrew?
Just like a lingering one is like going back to that blood pressure. Like we had the negative UA, right? I think it's your favorite and Reza's favorite, like trending the UA. And we already said this earlier. You know, this could still just be too early where we're not capturing it, but at like the level of the juxtaglomerular apparatus, like there is a ton of renin and aldo being released, which is why the BP is so high. So it is like a very curious thing. Like, why is the BP so high? Maybe oh no, his hypertension history. He doesn't take any meds. So he's like not someone who's on like 3 or 4 antihypertensives where it's like, okay, if you see a blood pressure in the 200s and he's on chronic 4 meds, like he very likely has this blood pressure that high. But here it seems like he's not on many meds and it's still very high. So it is kind of curious, like what is happening to drive that blood pressure up if he's like otherwise comfortable, which it seems like he is. So you know, in the setting of an acute presentation, you know, acute things that cause renin and aldo release that would cause BP to go up like this. You know, if you start at the large vessels, if you have like an aortic dissection or some sort of dissection going into the kidneys, that can cause ischemia to the kidneys and cause that to go up. But really at the microscopic level, you know, we're talking about small vessel vasculitis, you know, damaging that part of the kidney that drives the BP up. And I think we're thinking that since, you know, they're not having like tearing chest pain, we got the CTPE already. And we have a compatible syndrome here, like this pulmonary syndrome. But
Yeah.
uh, yeah, I'm grasping at straws, Charmine.
Yeah.
How much could we squeeze out of the aliquot that's been given to us?
No, yeah, I think like thinking back to the hypertension is a really great idea, especially if this is someone, these numbers are like really high, whether that's a kind of direct injury to the lung from the elevated, or it kind of, yeah, ties into something going on with the kidneys, right? Like anti-GBM or glomerulonephritis or something, and trending the UA. I totally agree with that. Yeah, so I don't think we're done with yeah, I'm not so quick to dismiss the inflammatory or like, anti-GBM syndrome effect in this patient yet. So I'm curious what happens next. Shreyas.
So yes, the anti-GBM antibody was also negative, and at this point we were lost for ideas. So we consulted Kirtan, and he came and analyzed this for us. And like I said, his blood pressure initially was very high, and then we controlled it. All it required was nifedipine 60 milligrams. His blood pressure actually went down after that, and subsequently his hemoptysis also was resolving. And Kirtan taught us that sometimes elevated blood pressure could just cause bland DAH like this because of elevated filling pressures. And for lack of a better explanation, we thought maybe it is just the blood pressures. And so we just, controlled his blood pressure pretty much. And that was actually all we had with regards to his investigations. And even Palm, they just talked about a lot of different things. Like autoimmune causes, ANCA was negative, and eosinophil count was normal. So Loeffler's was essentially not in the consideration anymore. And on the endobronchial, on the bronchoscopy, they did notice the diffuse alveolar hemorrhage, which we spoke about, but they didn't have any targetable thing to biopsy. So they couldn't get a biopsy. All they did was the BAL. And I think it's. I was just curious to hear your thoughts, and then I can reveal the final diagnosis.
Oh, so this is not the final diagnosis.
It is.
It is. Oh, okay,
Yeah.
okay. Yeah, my thoughts, I have a lot of thoughts on this. This is really interesting. This is a phenomenon. I saw this on the wards recently. What didn't fit, and I already gave some of my rationale for why I didn't think this was the case is when I've seen this, the chest X-ray is like very impressive. Like a bad DAH case has crazy paving where you're seeing both interlobular septal thickening and ground glass opacities, and it's like quite impressive. The lungs look pretty bad. In this case, it looked pretty mild. And, in terms of the venous pressures being so high, this must have been very acute because there were no pleural effusions. Pleural effusions often accumulate slowly, like that takes time for that to happen. So it was just an odd story that this guy just kind of came in like coughing up blood, and he wasn't like in respiratory extremis as the patients with flash pulmonary edema kind of have. So it was like an odd story for heart failure. But this happens, and if you want a fancy word to describe RBCs extravasating into the alveoli. Diapedesis, red blood cell diapedesis can happen not just in patients on anticoagulation, but just like on this where the blood pressures are very high. But yeah, I've never seen it present this way. Charbine, have you seen something present like this before? I'd buy it given that the CRP was so low and we have everything else negative. But what do you think?
Yeah, I think a couple of things. It makes sense. Then I think the question you have to answer is like why this guy's blood pressure is so elevated to cause this type of pathology. So are we dealing with like a PHO or like a secondary cause of hypertension or arterial stenosis? So I don't think we're done because we still need to explain as to why patient's blood pressure is so high that is causing whether it's like through, as you mentioned, like increased pressures, because like some pulmonary edema, and why does this happen, or like some injury to the blood vessels that is causing hemoptysis. And the other thing is like, oh, is this a more something that is could be episodic, or is it something that with time it would declare itself more? Probably not, because the patient got better. Or are we also dealing with like an infection of some viral type that got better? I don't know. But it is definitely plausible. But if we're invoking hypertension causing it, I think my biggest thing would be like then why the blood pressure is so high.
Yeah, such a good point, Charmaine. Yeah, not even done. It sounds like we have some like primary care engagement with this patient in terms of the past medical history. So it would be curious to like trend out, like you're saying, seeing his blood pressure log what that looks like, because the DDX for like chronic pi BP is the story of most of the endocrinopathies, like hyperaldosteronism, hypercalcemia. Whereas if it's like very paroxysmal, it's more like pheochromocytoma, like you said. So, um, yeah, Shreyas, take us home. What did you all find? Great case.
Sure. So I think at the end of the day, like I was saying, after controlling his blood pressure, his symptoms began resolving. But we still didn't just want to attribute it to that. The leading diagnosis was at the end of the day hypertension, which is leading to these elevated pressures, ultimately causing to DAH. But it was surprising that the patient was so hemodynamically stable, saturating well on room air. But then after his blood pressure was controlled, he started doing better. And his follow-up chest X-ray showed a complete resolution of nearly complete resolution of the initial opacities which we had seen. I can just share the follow-up chest X-ray. I think this was the follow-up chest X-ray just after controlling his blood pressure 2 weeks into, I think 2 to 3 weeks during the post-hospital visit. So I think at the end of the day, it was just very poorly controlled hypertension. And I believe he did undergo a secondary hypertension workup after his discharge. I'll follow up with the results of those.
And Shreyas, just to confirm, he didn't come in with like acute dyspnea, like orthopnea, nothing like that.
No, surprisingly, he just came in with like a tablespoon worth of hemoptysis, and actually he went back home because he felt better, and then he came back again to the hospital because he had it again at home.
Wow. Well, talk about atypical presentations of like common things. Thank you for bringing this. I think
Sure.
that sums up my final thoughts. Sharvid, what do you think?
Yeah, it's like super interesting. He went home, this happened again, which always like invokes what happens at home and like substances as well, which I think I'm sure y'all worked up for any like substance use that could do this, but like cocaine notoriously does this. So a really interesting case, Shreyas. Thank you so much. I love it when I have to think through all this like rare esoteric stuff and then comes out to be like not any of those things. So this is awesome. Thank you so much for sharing with us, Andrew. Always a pleasure, and I always learn new words and new things from you.
I always learn from you, Sharmin. Pleasure to discuss.
All right. Thank you again for to Himan for doing our teaching points. Mike, to
Is it?
you.
I'm sorry. Is it okay if I just share some thoughts which we had
Oh my
just from the
gosh,
team,
it
just
is
really
more
quickly?
than okay. Absolutely. Go ahead.
Yeah, sure. Yeah, so I just wanted to. So this was how the thought process was running in our heads. So we went over the DA head schema, and then we like essentially ruled out all of these stuff. And then infections, we ruled out leptospira. So at the end of the day, the biopsy was not done, so we really don't know if it could have been like pulmonary hemosiderosis or the isolated pulmonary vasculitis. And so just went over the schema for hemoptysis, which is essentially cardiovascular, pulmonary, and others from the frameworks of internal medicine. We had a very similar thoughts initially. So essentially all of this was ruled out with imaging. And for the ground glass opacities, we use the same framework, which you had gone over earlier. Pus, protein, and vascularities. Essentially, we had ruled out everything else. And this was the Palm's thought process as well, which was in their notes. So really no explanation about what was happening other than poorly controlled hypertension. And I found two case reports about the same thing, which go over how there was one case report about severe hypertension leading to a very similar presentation of DAH, which subsequently responded to just lowering the blood pressure. And it is, I also learned that it is quite uncommon for DAH to present with hemoptysis. I didn't know that. It's not really one of the characteristic manifestations. This is from the Harrison's textbook section on DAH, and DAH is only 0.2% of cases of hemoptysis, something else which I learned. So I think it was kind of a weird presentation. Yeah, that's all I have to say.
Brilliant. Thank you so much for sharing those notes. And it just speaks to what an awesome um, learner and physician you are to like take such meticulous note, think so deeply about a patient. So we really, really appreciate that. Thank you for sharing. And shout out to Jerome for doing scribing. Himan, Mike to you.
Yes, thank you so much for great discussion and great case. So approach to 58-year-old male with a 3-day history of hemoptysis. We have the false localization. We have to find out whether it's a squamous cell tumor in the mouth or affecting the mucosa or the nose. And also the quantity of blood loss in the, Andrew mentioned whether it's a tissue paper speck or towel size pulling like massive. And also place the injured lung on the affected side to improve ventilation is necessary. Diagnosis for hemoptysis include like alveolar issues like bronchitis, pulmonary embolism, pneumonia, TB, lung cancer, vascular malformation, and AV fistula. And social history of tobacco use related with the malignancy, but this patient less likely due to lack of a weight loss and acute one day is pointing to vascular involvement or bronchiectasis also and then TB also. Vital signs situation 95% is not safe yet, and high BP really indicating possibility of flash pulmonary edema. CT was showing the ground glass opacity, so we consider about blood, water, pus, and also differential include pneumonia, pulmonary edema, and anti-GBM, cancer, ILD, ANCA, glomerulonephritis, and we are thinking about renal analysis, autoimmune like ANA, C3, C4, ANCA, anti-GBM, CREO, and CRP, ESR, and coagulopathy, and most of them were normal and we will look for any possible bleeding cause and infection, and also because the patient was high blood pressure, even though the patient was not on the medication, evaluate kidney for aldosterone when related issues, and also interventional possibility of aortic dissection indicating kidney infarct, and the anti-GBM unfortunately was negative. And then the diagnosis was a severe hypertension, possibility of a hypoaldosteronism or pheochromocytoma or other possibility indicating diffuse alveolar hemorrhage. And the patient's people control improved the patient conditions. Thank you so much for amazing case, and I just want to say wish the best for those people who are applying for this match, and that's it.
Hewood, thank you so much. Yes, we wish the best for the matching folks. Please come celebrate with us next week, okay? Here to support you all.
Yeah, good luck, everyone. We're thinking about you. Thanks all. Have a good
Bye.
one.